Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is September 20, 2022, and I want to thank you for joining us on our Facebook Live. As always, we'll do a quick update on infectious diseases, what's happening with monkeypox, what's happening with COVID, but I'm really pleased to have two special guests here today. These are two of the medical directors at the City of Chicago and then at the state in the substance use prevention and recovery section. They're going to tell you a little bit more about it. So these are two doctors who spend their time thinking about how do we work on substance use issues here in Chicago and really across Illinois. So Dr. Wilnice Jasmine has been on with Facebook before, so you may recognize her at the Chicago Department of Public Health. She's the medical director for our behavioral health section, which includes the substance use work, but also our violence prevention work, as well as our mental health work. And then Dr. Nicole Gastala is new, I believe, to Facebook Live, but certainly not new to me or to the Chicago Department of Public Health. And I know you practice and then really leads this conversation on the medical side at the state level. So welcome to both of you. Do you mind just telling folks a little bit about your background and what we're going to be talking about so that they can put questions in?
Yeah, so I could give a start. So my background's in family medicine and preventive medicine. And today we're going to be focusing on our work through CDPH's substance use program. This latest program called MAR Now, talking about treatment and access to treatment for opioid use disorder. And I'm very excited to be here.
Great.
Thank you. I'm Nikki Gastala. I'm also family medicine and addiction medicine, and I joined Super a little over a year ago as their medical director. I still do clinical work in the West Side. I work at an FQHC system there, and I'm really excited to be here to share some of the evidence and clinical improvements that we've made, really to try to address the opioid epidemic in the city and statewide.
All right, perfect. And the reason that we invited both of these doctors is because we've been getting a lot of questions in about substance use, a lot of conversation, on social media about some of the harm reduction techniques we're having. And so we decided it was a good opportunity to do some education, but take your questions. As always, you can put your questions directly into the box below. You can also use the hashtag AskDrArwady on either Facebook or Twitter. We're going to go through a presentation, and then in about the last third of the show, we will take your questions directly. So as always, let's take a quick look at the COVID dashboard. CHI.gov/COVID-. We continue to update this Monday through Friday. And as you can see, really everything on this is green, and that means good. Things are looking really reasonably good from a COVID perspective. COVID is certainly not over, and I've gotten some questions, so we will address that a little later. But what you can see here is that cases are down, hospitalizations are down just a bit, deaths are down, emergency department visits are down, hospital beds are down. But down does not mean over. When 3.8%, about 4% of our hospital beds across Chicago are taken up with patients with positive COVID tests, that means 1 in 25 hospitalizations still is being affected by COVID. A number of people were asking, how are we doing with the updated booster, the new COVID vaccine? So, just to remind you, you can click and sort of see. So this really sharp uptake here is the updated booster. And I'm quite pleased by how quickly this uptake has been in that first sort of week or two. You can see compared, this is just vaccinations in Chicago over time, COVID vaccinations. This is actually one of the quickest uptakes that we've seen. I do want to highlight that this was also more widely available than in some cases. Like historically, only people of a certain age or with certain risk factors. And this is really a reminder, everybody over the age of 12 should be getting this updated booster, but still pretty good uptake. So you can explore more about vaccines on the dashboard. But let me go ahead, let me go ahead and pull up the slides here. And we'll do a quick infectious disease update. And I'm going to go through these pretty quickly because those of you who follow every week know, more or less what's happening here, but we do post them online as well. So on monkeypox, the news also there is reasonably good, but definitely not over. So across the whole across the whole world, the number of countries continues to grow week after week. We now have had cases in 104 countries. And reminder, all of these orange dots are countries that do not historically see monkeypox cases. cases. The blue dots is where historically we've had monkeypox, really in interactions with animals, but this instead is a really human-to-human spread, and we're up to about 62,000 cases and continuing to grow. Across the U.S., every state has had MPV cases, about 24,000. Illinois has had about 1,200 of those cases, and Chicago this week will pass the 1,000 mark for MPV cases in Chicago residents. Trends overall, this is national, on new MPV cases are downtrending a little bit. This is good news. This is a combination of vaccine, but also behavioral change. And this is where, when we're thinking about harm reduction, which we're going to be talking about on the substance use side, where people are making some changes at a time of increased concern to limit the risk for monkeypox. You know, having fewer new sexual partners, having conversations about whether people are having monkeypox sores. You know, these kinds of things are actually an example of harm reduction. So we're seeing some decline there, but it's still a lot of cases. And in Chicago, almost every community area, we've had at least one MPV case, 69 of 77. This is what our local curve looks like. So you can see week over week, you know, we peaked in late July, early August, and then have come down, but you can see that it's not really down to nothing. And I think we are likely to continue to see, you know, a reasonable number of cases. So we're glad to see that decrease, but definitely the risk is not gone, and it's changing demographically, which we often see in outbreaks. We are now seeing a higher proportion of new MPV cases in Black Chicagoans, and let me just show you that data. So this again, each of the bars is a week, and over July, August, September, and at the beginning, the red bar are white non-Latinx Chicagoans. Most of our cases were really in white non-Latinx Chicagoans. Blue is Latinx, green is Asian, and then purple is in Black non-Latinx Chicagoans. We were not seeing a lot of early cases among Black men, but you can see that week over week, a larger percentage of our cases now are in Black Chicagoans. And what we have seen, and I'll just move to the demographics here, and you can look all of this up on our website if you want to dig into it in detail. Very much still, 94% of Chicagoans who have been diagnosed with monkeypox self-report their sexual orientation to be gay or bisexual. But particularly among Black Chicagoans, we're seeing more younger men being diagnosed. We're also seeing more men who are less likely to report being gay or bisexual being diagnosed. And so it's just important, as a reminder, if you have a sore, you don't know what it is, you know, please go see a doctor. You can get tested for MPV anywhere across the city. And if you get tested, your close contacts can be vaccinated to help stop the spread. So overall, at this point, about 26% of the cases in Chicago have been in Black Chicagoans, but it's just that increase has been there. And we want to get that news out. We've seen less uptake in both Black and Latinx Chicagoans of MPV vaccines. So that's something we've really been working on. Whereas 27% of MPV cases at this point are in Black Chicagoans, only about 13% of MPV vaccines have gone to Black Chicagoans. Similarly, in blue there, about 30% of MPV cases have been in Latinx Chicagoans, but only about 18% of vaccines. So there is vaccine also widely available. If you are not sure how to get a vaccine, I'm going to show you the number to call, and we really, really want to make sure that everybody who is at increased risk is getting vaccinated at this point. Here are what our vaccination numbers look like in Chicago for monkeypox. We've done about 35,000 total doses. In blue, our first doses, and in red, our second doses. So you can see at this point, a lot of our vaccination are second doses. The second dose comes at least 28 days after the first dose, and already we've got some data suggesting that second dose is really important. We've seen people who had only one dose of vaccine get diagnosed with MPV after, sort of later. And so strongly encourage anybody who's gotten that first dose to make sure that you get the second. But also we are seeing new vaccinations trail off, and there are a lot of people who we do recommend it for. This is, you can look online if you want. Not surprisingly, there have been very few children vaccinated for MPV. It would only be close contacts of a known case, but you can look at the demographics more online if you're interested. We actually have an excellent match on race ethnicity for our monkeypox cases and treatment. So there's a treatment called TPOXX that if for people who are at higher risk for severe outcomes or people who are seriously ill, we really want to get people treated. And this is actually, you can see that whereas about 27% of our cases have been in Black Chicagoans, about 30% of the folks who have received treatment have been in Black Chicagoans. So this is what I would like the vaccine numbers ideally to look like. But it tells us that we actually have reasonable access to treatment and folks, getting into care, but the vaccine is still to work on. So in case you missed it, all sexually active, gay, bisexual, and other men who have sex with men are eligible for and should receive 2 doses of the monkeypox vaccine. Also, all sexually active transgender persons. We've got plenty of appointments at this point. Just to give you a sense, CDPH has 6 days a week. Clinics happening in Lakeview, Austin, and Roseland. You can register in advance. And if you don't know what to do, you might have symptoms, you want a vaccine, you're not sure where to get a doctor, give us a call 7 days a week. We will help get you connected to anything that you need. So we're doing pretty well there. And then even more quickly on the COVID front, if you look across the world, things are a little bit calmed down there too. You can see this very darkest purple is usually where we're seeing significant outbreaks. There are still a few parts of the world, but overall, right at the moment, largely because we haven't seen as many new variants emerge, things are a little bit calmer than they have been, and that's good news. Same thing across the U.S. Really, Appalachia continues to be, I'd say, the primary area where we're seeing a lot of spread, but Chicago is below both the national rate and the Illinois rate for new cases. And for the first time in a long time, this is also looking better. So every week, the CDC designates every county in the U.S. as high, medium, or low risk. And for the first time, less than half of the counties this last week were at either a high or medium risk. And, during the big surges, almost 100% have been at high or medium. So you can see that Chicago and Cook County remains yellow in that medium risk. And for those of you who like to follow the numbers, to get down to low risk, what we would need to see is to see fewer hospitalizations across all of Cook County. And it's actually not just Cook County, it's sort of the regional area. So if this number comes under 10, and we're getting close, this is 10.7 new admissions per 100,000 population over the last 7 days, we're actually in a good place for cases for both Chicago and Cook. And Chicago now is seeing just under that cutoff for hospitalizations. So, we really are medium or on the edge of medium toward low. The reason for that predominantly is that we've not seen sort of a new scary variant emerge in a while. But I do want to highlight the good news is that everything we're seeing is all Omicron. Again, every line here is a different week, and all of the different variants are subvariants of that Omicron. You remember Omicron, when it hit us so hard last December, January, the worst we've been hit yet. And really the big question is, as we move into the cold weather, will we see something with as much variation of Omicron? But even within Omicron, we are starting to see a little bit of a change here. So those of you who have been following closely, this BF7, it's the first time we're calling this out. It's just 2% of the cases. It's an offshoot of BA5, but it's got another mutation in it, in the spike. And then similarly, this BA 2.75, if you look up at the top, do you see how typically the dark green here is BA5. That's still most of the cases. Usually we see that one come and kind of outcompete and a new one come in. It's a little unusual to see this BA 2.75 growing again after it had shrunk and the BF7 we're watching. So the bottom line is that right now, that updated COVID vaccine remains a beautiful match. Remember, it's not only boosting against the original versions of COVID, for the first time, it's an update to the vaccine, and it covers BA4 and BA5. And when you get that updated vaccine, it also helps to protect against the emergence of new variants. It helps give protection as variants emerge. And so this is why we've been saying, please don't wait 3 months. We really want folks getting this now. now while it's such a good match. About 13% now of our kids under 5 have gotten a first dose of COVID vaccine. I'm really disappointed by that, I gotta be honest. We are seeing outbreaks, especially in preschools, some of the young kindergartens, and some of that is due to lower vaccine uptake. Yes, we are more than twice the national rate, but I remain concerned, about the youngest kids and would encourage people, even if they're not eligible for the updated vaccine, which is for those over 12, to also get kids up to date. These new bivalent boosters we've been talking a lot about, they are here. We've done about 32,000 doses in the first kind of week and a half or so of the rollout. We've got some data online sort of showing, we've got 1.71 million Chicagoans who are due for this updated booster. So 30,000 is a good start. 30,000 against 1.71 million is a very small percentage of who we need to get this vaccine. And if you look at the demographics of who has received this vaccine, we are seeing older adults being more likely to get it. This is just the breakdown of what percentage, have been there. But there's just a long way to go. And here, too, we are seeing this major disparity in terms of race and ethnicity. So if we look back here a second, among those who are eligible, about 35% are white non-Latinx, 27% are Latinx, and 23% are Black, because you have to have had the first vaccines to be eligible. But in terms of who in that first week and a half or so, about 65% of our doses here have gone to white Chicagoans and about 12% to both Black and Latinx. And we have seen every time we've had a surge, COVID hits harder in Black and Latinx communities. And so strongly encourage everybody over the age of 12, if you're due, get this updated vaccine, but especially if, in Black and Latinx communities, we're doing a lot of outreach. There are hundreds of places you can get this vaccine. I'm a little worried about flu season. Australia has had a very bad flu season this year, and when the Southern Hemisphere has a bad flu season, it tends to predict a bad flu season for the Northern Hemisphere, given our opposite seasons. So you really do not want the combo of getting COVID and flu together. Please get both vaccines now. This Saturday, we have 2 large clinics where you can get both of those done in one fell swoop. You can get your flu vaccine and your updated vaccine or your original COVID, any age, at Richard J. Daley College and Wilbur Wright College. We do also have the $50 incentives available for first, second, and booster doses, as long as people have not already received $100 of incentives, and that's a federal limitation there. But please come on out, just get it done. We really are able to move people through here in a very short amount of time. People have been texting me, I got in and out in 20 minutes, and it's a good way to do it. But there are lots of other opportunities. Go to chi.gov/COVIDVax or Vax Calendar. Here's where the other city colleges will be. We've got city hall clinics. There are literally hundreds of churches, aldermanic locations all across the city, and they are available in pharmacies and through your doctors. Our at-home program is going strong, so if none of those work for you, give us a call. We'll bring vaccine to your home. We're prioritizing, at this point, older Chicagoans and less vaccinated zip codes. We were getting a lot of questions about long COVID, and so I thought I would bring here, there are definitely opportunities if people either are or are not having long COVID symptoms to enroll in some of the large national studies that are going on to help us learn about long COVID and understand what the risk factors are. And so this is posted on our website, but these studies, look, they're open to people who currently have COVID, who had COVID in the last 30 days, or who have never had COVID. And there is some opportunity if people join studies, you can get paid for your time, but really it's to help us answer over the next years what this is going to look like long term. And there are sites right here in Chicago that you could enroll and be part of some of these studies. So as always, any questions about infectious diseases, COVID, you need help finding a doctor, you need help generally related to the Chicago Department of Public Health, give us a call, 312-746-4835. And with that, I'm going to hand it over to Dr. Gastala and Dr. Jasmine to talk about National Recovery Month and some of the substance use work. Go ahead.
Fantastic, thank you. So we're really excited. This is National Recovery Month, and one of the hardest things in the country right now is the opioid epidemic, and more than 20 million Americans are recovering from substance use disorder. Recovery Month really celebrates the gains made by those in recovery from substance use and mental health. So really focusing on improvements made by those who are managing other health conditions. It was first observed in 1989, and so now we hold it every September, and it's really to promote and support new evidence-based treatment and recovery practices for substance use disorder. And we really want to define what recovery is, right? It's a process of change where individuals improve their health, wellness, live self-directed lives, and strive to reach their full potential. So it isn't just for those who are in abstinence, but really anyone who's on that road to recovery. So for substance use disorders, when we think about that, well, what does that actually mean? How do you diagnose that? Well, it's actually recurrent use of alcohol and drugs that cause clinical significant impairment. So changes to someone's health, cause a disability or failure to meet sort of major responsibilities at work, school, or home. It's a common, chronic, and treatable with both medication and behavioral therapies. It affects a person's brain, body, and behavior, and this is why it's a medical condition and not just sort of a character flaw or choice. It needs to be diagnosed by a medical professional. It can oftentimes occur with a mental health condition and absolutely be tied to an individual's attempt to cope with trauma. So we really do see a higher prevalence in those who've experienced trauma. One thing that it's really important to understand is that substance use is not a personal or moral failing. It's not a character flaw. It's not a choice. It's not something that someone has complete control over, just like diabetes, right, or hypertension, or some of the other health conditions that we treat that require both medication and behavioral and support.
Okay, so for those who work in public health, our main effort revolves around prevention. And when it comes to stigma, we are in a unique position to reduce the stigma surrounding substance misuse. So stigma is the discrimination against an identifiable group of people, a place, or a nation. And stigma about substance use disorder might include inaccurate and unfounded thoughts, like they're dangerous or it's their fault for their condition. It is completely inaccurate to believe that having an experience and experiencing addiction is a moral failing, like Dr. Gastala mentioned. And we know that addiction, again, is a chronic condition that's treatable, that people can recover from, and that people, once they're in recovery, can continue to live full, thriving lives. And so what makes stigma especially concerning is that because of the ideas that persist about someone with a substance use disorder, it may be difficult for them to enter treatment or reach out to providers that provide support for them to enter recovery. And so stigmatizing views of people with substance use disorder, they're common, and this stereotyping can lead people to feel pity, to feel fear, to not reach out to get to know those with substance use disorder. And it's important to know that addiction can affect anyone. And if you want to see what someone with a substance use disorder or an addiction looks like, all you have to do is look in the mirror, because it can impact any one of us. And so here, this slide talks about language matters. There's power in the words that we use. And that is why the language we use matters. And so when we're thinking about words like abuse, use use in term or misuse in term instead. Think about addict or junkie, abuser or user. Instead, use the person first language. So a person with substance use disorder or person with inactive use. What's important about person first language is that it maintains the integrity of individuals as whole human beings, and it removes the language that equates people with their condition or has negative connotations. So similar to when you're thinking about alcoholic or drunk, think of person with alcohol use disorder, person who misuses alcohol or engages in unhealthy or hazardous alcohol use. The word clean is something that is commonly used. I see it also in reporting in medical journals too. Instead, try to think of words like new or sterile. When you're talking about lab results, think of it as positive or negative. If it's a person who's in recovery, use that term, person in recovery. Same thing goes for dirty. So rather than stick to using dirty, think of it as used, or if it's a test result, someone's screening positive or negative. Same thing for habit, drug problem. Think of substance use disorder. And today we're talking about treatment. One of the myths around is that the medication treatments are replacements or substitution therapies, but really the medications really assist people to maintain their recovery. Again, when we're thinking about detox, think of withdrawal management because it is actively providing medications to help support the person's symptoms of withdrawal. And then when you're thinking about sober, think more of a person in recovery. So again, there's tremendous power in the words we use, and we encourage all to be respectful and to recognize that we are all on this journey called life together. So we have areas that need more focus when we think about each of our individual circumstances. So we shouldn't judge those who have substance use disorder.
Great, thank you, Dr. Jasmine. So one of the important areas to understand, and Dr. Jasmine highlighted, is that there are evidence-based practices for treatment of opioid use disorder. There are 3 medications, buprenorphine, methadone, and naltrexone. And these can be used independently or together with behavioral therapy like counseling or group therapy to be effective. And really understanding that medication-assisted recovery is actually the standard of care for opioid use disorder and should be offered to all patients who have opioid use disorder. But the reality is that only 87% of patients nationwide with an opioid use disorder, most of them do not receive MAR. And if we think about comparing that to other health conditions, can you imagine having someone with diabetes and having 87% of the nation not have access to insulin or other medications? So this is a really big challenge that we have in this country and in the city of Chicago and the state, that we really want to improve access for patients, to help improve outcomes and another important thing to understand is that the evidence really shows that medications are effective, and they are effective in terms of reducing, improving harm. So compared to behavioral therapy alone, which again is counseling, MAR is known to decrease illicit opioid use, it helps people stay in treatment, and it reduces mortality. So patients on buprenorphine have a 40 to 80% lower risk of fatal overdoses compared to those not receiving buprenorphine treatment. And this is really important, right? Because even if our number one goal for patients is to improve their lives and improve their outcomes and impact morbidity and mortality, and we can't do that if they've passed of an overdose, right? So it's really, really important to meet patients where they're at. One thing that's really important to understand too is that for opioid use disorder specifically, detox or supervised withdrawal is not effective treatment, and it can actually increase the risk of overdose if there's no linkage to the next level of care. Again, this is specific for opioid use disorder, so if you have a problem with opioids and you're thinking, I've got a heroin problem, detox or supervised withdrawal isn't really your best treatment. It's really medication stabilization. And the studies show this, right? Patients who are on medication have much better outcomes at 12 months compared to those who just do therapy alone. It's only about 6% if you do therapy alone. Or if you do buprenorphine or methadone, it's between 60 and 90%. Again, so really impacting a person's morbidity and mortality, helping stabilize them, helping them to engage in recovery support services. So all of those things that are really important to help a patient live their best life. So really thinking about it, do you have a problem with opioids? Does your family member, a loved one? Again, like Dr. Jasmine said, this is an equal opportunity disease, just like diabetes and hypertension, and really factors strongly in if we've experienced trauma as a way to cope with trauma. And so if you're having problems with opioids like heroin or fentanyl, buprenorphine and methadone can stop those withdrawal symptoms and cravings and reduce your opioid use. And I'm going to talk a little bit about the two medications. So one is buprenorphine. So when can you start that? Well, you really want to wait about 12 to 24 hours after your last use. It comes as a film or a pill initially that you can dissolve under your tongue. And there's also a long-acting injectable form that you can be transitioned to. So you just have to get that once a month. It's really effective if you take it for 9 months or longer. And you can call this number, which we'll talk a little bit more about. If you compare that to methadone, you can take that immediately. One of the challenges is you do have to go every day to an approved program and receive in-person dosing at the beginning, and then eventually you'll qualify for take-home dosing. It's really most effective if you use it for at least a year. And studies actually show, just like any other medication, the longer you take it, the better you do. As long as you're not having side effects or there's no contraindication, you should really be on it. So how do you get access to medication and services? Well, you can call the Illinois helpline at 833-234-6343 and say that you want help for opioid use. And they'll connect you to Medication Assisted Recovery, or MAR now, which is a new program that we're going to talk about. And one of really important thing is you don't need access to insurance in order to access this. You don't have to have citizenship in order to access this. So this is really for anyone who has a problem with opioids. We really want to impact mortality and impact the overdose rates in Chicago and Illinois.
And so what really made this MAR Now program able to launch is that at the beginning of COVID, the federal government, the regulators really removed a lot of restrictions or waived restrictions to allow low barrier prescription care. And so one of the first changes they made was that they allowed that buprenorphine to be prescribed using audio-only telemedicine, which was very revolutionary. It gave recognition that not everyone has access to video conferencing or has large data plans to conduct their medical care. A second change that was made was that the in-person examination with the provider before your first dose of buprenorphine was waived. And so this also was very helpful because we know, especially outside of Chicago, that it may be very difficult to find a person to prescribe buprenorphine, and so someone may have to travel hours to reach a clinician to prescribe that medication. And so if the visit can be done through either audio or video conference, then that would eliminate that need, that barrier of traveling long distances to get that care that's needed. And then buprenorphine providers, they can use non-HIPAA compliant platforms to reach patients. And so that also is another barrier that was eliminated. Very easy to get a Zoom account or a WebEx account without having to go through an EMR, which can cost tens and thousands of dollars to implement for a practice. And so these changes, they allowed states and cities to implement buprenorphine hotlines or telebuprenorphine clinics where buprenorphine initiation is conducted over the phone and video. And so much like in some other states, here in Chicago, we're very happy that we were able to work very closely with the state to become the pilot site. And even more happy that this pilot period, there was no delay in expanding it for the whole state. And so we're improving access to care, simply calling the Illinois helpline. So you see that number there, 833-234-6343, and just ask for, say that you want to start treatment for opioid use disorder, and you'll be connected to care. And then, so at the end of August, the last day of August is known as International Overdose Awareness Day. We really, it's a day that commemorates those who died from an opioid overdose. Their friends and family really do, there are different activities throughout the city that commemorated this date. And then the whole of September, we celebrate Recovery Month. And so part of that recovery is making sure that people are alive to actually make the decision for when they're ready for treatment to enter treatment. And part of ensuring that happens is that we have partnered with our city public library, Chicago Public Libraries, to really make sure that Narcan is available throughout all the community areas in the city. So we currently have it available in 51 sites, and then before the end of the year, all of the Chicago Public Libraries will have this medication. All you have to do is just walk in and without any questions asked, grab the Narcan. On the box, there are instructions on how to use it. And then if you want online, there are also short trainings on how to use it if you don't feel comfortable using it. The idea is that you'll never know when you'll encounter someone who is experiencing an overdose. And if you have that tool ready to use, you can really impact that person's life. So sometimes you may wonder, what are the signs of an opioid overdose? So if you encounter someone and you know them, you try calling their name, they're not really responding. If you see that they're breathing really slow, their breathing may appear shallow. They may have a gurgling sound when they're breathing. If you try to arouse them, rubbing on their sternum or over their lip really is painful. And so if you try doing that to someone and they're not responding, those are all good indications that someone's experiencing an overdose. So what you would do is call 911 so that help can come. But while you're waiting for help, if you have Narcan available or naloxone, what you can do is really just spray the medication up the person's nostril. Wait 2 or 3 minutes. If you see that they're still not awake, you can give a second dose, and hopefully by that time the emergency medical services would arrive. And then in another effort to really make sure that people who aren't quite ready to enter treatment yet, if they're currently actively using drugs, to make sure that they are informed of what the composition of their drugs are. So we also are distributing fentanyl test strips. So it's very easy to order. All you have to do is either email us at osu.cdph@cityofchicago.org, or you can even come to one of our mental health clinic or STI clinic locations to pick it up, no questions asked. You can even come to our main office at 333 South State Street on the 2nd floor. You really can take it, and the idea is that if you're informed about the presence of fentanyl in whatever substance you use, we know fentanyl it can be found in drugs other than heroin, so it could be cocaine, methamphetamine. If a person tests their drug and see that there is fentanyl in it, we're hoping that they use that information to make certain behavioral adjustments. So for some people that looks like using less of the drug, others is making sure that they're not using the drug alone. So in case they overdose, there's someone there to respond to the overdose. Some people, they just use less over time. So whatever you're comfortable with, we're hoping that information will help serve you and keep you alive. And again, our MAR program, calling the Illinois helpline, will really connect you to care the same day or the very next day. And what's great about this program is that if you call and you're immediately connected to a care manager who will work with you to address any barriers you may have to treatment to get it the same day. So if you have transportation issues, they can arrange transportation for you to either go to the clinic, or if you're eligible for home induction, you can go get transportation to go to the pharmacy to pick up your medication. If you don't have insurance, they'll work with you to obtain insurance. But you don't have to have insurance to use this service. You don't have to be a citizen to use this service. It doesn't really matter what your income level is. It's available for everyone here in Chicago and now across the state. And again, it's very important to remember the idea of reducing stigma. It starts with you, so being conscious of the language that you use and really being aware that how you treat others really can impact how those who use substances, it may contribute to their reluctance to enter treatment. And then we would be remiss without also acknowledging that September is it's a National Suicide Prevention Month. And so our emphasis today has been on treatment for substance use disorder, but we also know that every September we help raise awareness and share information about this public health concern, which is suicide. And so there are many intersections of suicide and substance use. As Dr. Costella mentioned earlier, many individuals who experience substance use disorder, they also may be experiencing a co-occurring substance use disorder, meaning they may have a mental health condition in addition to a substance use disorder. Sometimes it's a substance use disorder that starts, that is evident first. Sometimes it's a mental health condition that's evident first. And then some of these examples of mental health conditions that can co-occur include depression, anxiety, ADHD, could be bipolar disorder, or schizophrenia. And because there is such an overlap, there's a need to treat both together. And so here are some warning signs for people who may be contemplating suicide. So when you're thinking about, when you talk to them, they're talking about wanting to die. They're looking for a way to kill themselves. They're talking about having feelings of hopelessness or having no purpose. Sometimes they talk about feeling trapped or being in unbearable pain. It could be both psychological pain or physiological pain from undertreated pain. They could be withdrawing from their normal social activities and feeling isolated. Sleep is another key change, so someone can be sleeping too much or too little. And then increasing use of alcohol or drugs. Again, that's the bridge between what we're talking about, our MAR now, and then also acknowledging National Suicide Awareness or Prevention Month. The person may be acting anxious or acting recklessly, showing rage or talking about seeking revenge. They also may talk about feeling like they're a burden to others. And so when you think about drinking or using drugs, that can change behavior and mood. And so drug and alcohol use, they may lower a person's inhibitions. They may worsen feelings of depression or distress and increase impulsivity. So if the person has suicidal thoughts, they're more likely to act on it. And so drug use impairs judgment, affects the brain that controls behavior. And so when we think about someone who has substance use disorder, they may also face a lot of stigma from society, and that stigma increases that sense of hopelessness. So anyone with any one of these signs by themselves are not associated with increased risk of suicide, but in combination of these factors, if you have a combination of them, they may be more likely to have or commit suicide. So if you notice that in yourself or in a loved one, it's important to know that you can reach out for help. There's always someone here who can help you. And so our final slide, we talk about how there is hope. The 988 Suicide Crisis Lifeline was something that launched across the nation over the summer. And so these are 5 action steps that you can take for helping someone in emotional pain. You can interact with them by asking how they're doing. If you notice that they may have a means to harm themselves, see if you can move those means away, whether it's through medications or a firearm or weapon. Be there for them, and then you're not alone in trying to help the person. Calling 988 provides a whole host of resources and connects you to mental health, professional mental health clinicians. That's it.
All right, great. Thank you. So lots of questions here. And as always, we can end the slideshow here. As always, we'll sort of go back and forth between some of the COVID infectious disease and some of the substance use related questions. If you're joining late, this is Dr. Wilnice Jasmine of the Chicago Department of Public Health and Dr. Nikki Gastala at the Substance Use Prevention and Recovery Division at Illinois Department of Human Services. So at the city level and at the state level. So while we move into this next section, why are opioid overdoses surging so much here in Chicago, across the state, across the country? You know, I've heard lots of opinions on that, but I'm curious what both of you have to say. So do you want to start us off, Dr. Gastala?
Sure. I think one, it's a combination of many things, like anything else, right? The first thing being that we're seeing a lot more synthetic opioids, such as fentanyl and carfentanil, in the drug supply, and that has a much, much higher potency than heroin does. And so unintentional, consequences of that. So say you normally buy a dime bag of heroin, right? But normally it has 4% of fentanyl, but the next time you buy it's 9 or 16%, that's going to cause you to have an overdose, and it's hard, you can't tell the difference, right, until after you use it. And so a lot of it's unintentional. The other thing that confounded it was COVID, right? We asked people to stay home, we asked them to shelter in place, and using alone we know has higher risks. And so I think those two confounded one another, and then really contributed to the increased overdose that we've been seeing.
I agree with that.
All right, good. So there's a number of both comments and sort of different opinions about this. Let's do one more kind of opioid substance use focus, and then I'll take some of the COVID ones. So we've got comments from Jordan on Twitter, Christian on Twitter, Nikki on Twitter, very positive, saying, I gotta say, it's a big city, a city realizing drugs will be used, doing what they can to prevent deaths, and to top it off, libraries have life-saving tools. Libraries are more than just bookshops. Thank you, Jordan. Christian saying, it was great to see proactive harm reduction at Riot Fest. This was a big festival, and we did a lot with making sure Narcan was available. And then Nikki on Twitter says, great to see important public health resources, being discussed. But then there's also really some opposite responses, and this is what we often see when we talk about this issue. Yvette on Twitter says, is this really what public health departments have come to? What in the world? Wow. There are no greater public health issues to focus on, she asks. M from Twitter says, Chicago Department of Public Health really wants people to test for the presence of fentanyl in whatever Coke, Molly, or smack they might casually indulge in over the weekend, because we live in a total normal society. So often when we talk about this issue, we know that people have strong thoughts and opinions on this. So, thanks to the folks who are saying, this is something, but this is a real conversation. So, for both of you, why don't we just say stop using drugs?
Well,
that's an excellent question. So I think the challenge is I would counter and say, well, why, when we talk with our patients with diabetes or have high blood pressure, why don't we say, oh, just stop eating salt and stop eating sugar, right? So we know that substance use disorders is a health condition, right? We have evidence of that. There's a genetic component, there's an environmental component, and there's a behavioral component, just like diabetes and hypertension. So I think one thing that's really important for the viewers and the public to understand is that we have evidence that this is a health problem. If someone could just stop, they would. And the reality is that any patient that you've talked to that has substance use disorder, it's not a choice, right? When they were little, when they were deciding what they wanted to be when they grew up, they did not anticipate that this was going to be part of their life. And just because someone uses drugs occasionally does not mean that they have a substance use disorder. And just because they use occasionally doesn't mean that they deserve to die, right? And I think as a public health entity, our responsibility and as a society is really really to help keep people alive and keep people safe. And we do that in many other areas of harm reduction, right? We do seat belts to prevent to help prevent death from motor vehicle accidents, helmets, right, for bikes. We have condoms to prevent STI testing and unintended pregnancy. So we use these sort of modalities in other areas. It's just more triggering in the substance use field because there is been a lot of history about moralization and criminalization of substance use, which makes it a little bit viewed more inequitably than other health conditions that we treat, even though that there's evidence that it has the same level of genetic, behavioral, and environmental component.
And on top of that, to think of it as why we in public health are responding to it. When we think about all the headway that's been made with treatment of conditions, chronic conditions like diabetes or high blood pressure or prevention of strokes, we're seeing fewer people die of those conditions, but we still continue to see many people, an increasing number of people, die of substance use disorder and overdoses. And so as a public health entity, it is our responsibility to make sure that not only to report that we are seeing these numbers increase, but to see what programs and interventions we can make to try to decrease the numbers that we're seeing.
And I would just add to that I don't think this is very widely known. More people die in Chicago every year of an opioid overdose than die of gun-related homicide and car accidents combined. And when you're talking about something that is a major cause of death and that death is preventable, whether we want to talk about it or not, there are people in this city suffering from it and many people dying from this. And we see deaths from opioid overdose in every community area. So I think people have a tendency to think that if they haven't been personally, if they don't have a substance use disorder, they may not recognize, like, there are lots of people with substance use disorders that you might not know that history of. And one of the reasons I really like the way you folks, we're highlighting some of this, how do we get away from stigma? How do we think of this as a treatable disease? Because it is a treatable disease. So, that's one of the main reasons why the public health department is working on this and proud of it. And it's a difficult topic, it's a difficult conversation, but it's the same reason we don't say it's not realistic to say stop having sex, right? If there are concerns around sexually transmitted infections. It is absolutely right and appropriate to say, here are the things you can do to help protect yourself against sexually transmitted infections, right? So that's kind of the idea. All right, let me just hit a couple of these COVID questions real quick. So Caitlin on Facebook is saying, Dr. Arwady, personal question for you since you recently recovered from COVID. With these different subvariants emerging, does this change when you plan to get your bivalent booster? So good question, Caitlin. Those of you who have been following know that this is what, one of the things I've been saying. As a reminder, everybody should go ahead and get that bivalent booster if it's been 2 months since their most recent COVID vaccine. So if your most recent COVID vaccine was a year ago, great, get your booster now. If your most recent booster was a month ago, you should wait 2 months. But for people who have recently had COVID, what the CDC has said is you do not have to wait, but you might consider waiting up to 3 months. And that's not because there's any danger to you. If you get the vaccine earlier, it doesn't hurt you. But when you've just recently recovered from COVID, you actually have quite a lot of antibodies and protection, and thinking about wanting to sort of extend that level of protection. So I had COVID in late August, and I have said, and I absolutely will, the very latest I would get that updated vaccine would be November, therefore. I am not planning to get mine just yet based on those variant changes that we're seeing. But if over the next couple of weeks we were to see one of the variants emerge and that really start to change, yes, I probably would get it a little bit earlier. I also don't have significant underlying conditions, and for some people they may decide to get it earlier. But no, at this point, my current plan is to get it in November. Rachel from Twitter, are the ingredients of the new COVID booster different than the original vaccine? I'm concerned that while I don't have any allergies to the first vaccine, might the new one possibly cause problems? Another good question from Rachel. So when we think about the ingredients, most of the ingredients, quote unquote, in a vaccine are just delivering the instructions to your immune system. So often what people actually, if they have allergies, it's more like they have allergies to some of what we use to protect the instructions, as opposed to, there's not toxins in these, et cetera, et cetera. It is extremely unlikely that you would have any allergic reaction to this one when you didn't have one to the last one, because nothing has changed in the technology. What has changed a little bit are the instructions to your immune system to better match the way the virus has changed. So for example, where we have seen the virus mutate and the spikes sort of look a little bit different, the updated vaccine has those directions to help your immune system better recognize the spike. But in terms of, the fat globule that it sits in, or the salts and sugars that make it the right pH for your body, none of those are significantly different. So I don't have a concern about people developing an allergy because the technology is really the same. And I'm going to take one more COVID and then we'll go back to you guys. So a number of people have written in saying, President Biden said the pandemic was over. Do you agree with him? So for those who may not have been following, on 60 Minutes, in the context of multiple conversations that the president was having about COVID and how it's impacted and some of the work that's happening, he said, in his opinion, the pandemic was over, and that got a lot of attention. What I will say is that thankfully, we are not in the same place from COVID-19 as we were in 2020. We have vaccines, we have treatments, we have widely available tests. And whereas early on in COVID, when none of that was available, there was actually not very much that people could do to help protect themselves against those severe outcomes. As those tools have come into practice, this has become a disease that we can protect ourselves better against. But I do believe, whether you use the word pandemic, whether you use the word endemic, very, very clearly, we can be thankful that COVID is not, and hopefully will not, need to disrupt our daily lives like it did in 2020. But the virus continues to mutate, the virus continues to adapt, and we need to do that too. So it's a different phase of the pandemic, thankfully, but getting folks up to date with their vaccines is the most important thing that you could do to help us stay in this place where we remain concerned about COVID. Hundreds of Americans continue to die every day from COVID. And while that is true, we can't say COVID is over as a concern. But I think what he was likely referencing, and what is different, is that it doesn't need to be the first thing that we are thinking about as we are thinking about health risks and as we are thinking about indirect harms of COVID. And in that sense, yes, we are at a different place, but COVID is not over as a disease, and honestly, I don't think it will be probably for perhaps the indefinite future. And so using the tools that are now available help us keep this manageable. So those are my opinions on that. Couple of questions again for Dr. Gastala and Dr. Jasmine about how the legal part of this fits in. So I see a question here, Brandon on Facebook, saying, if I know someone struggling with a substance use problem and I want to get them connected to help and I want to get them connected to treatment, is there a chance that they could get into legal trouble if they're calling and asking for help? Like if they call the MAR now line and say, I have a substance use disorder, right? Like I would like to get connected to treatment. Are there legal implications for that?
So anyone who has a loved one can call, and the patient themselves can call too. Mm-hmm. And there is no legal implication. This is a health condition that we're trying to treat. So I would encourage you to find all the resources that are available. And there's a lot that you can do. Your loved one may be in the contemplative state, right, where they're ready to engage in treatment, but they may be in pre-contemplative, right, not quite ready. And that's where some of the harm reduction strategies can be really, really helpful. Mm-hmm. And love them until they're ready to love themselves to move to that next stage. Mm-hmm.
Yeah. And as having a loved one in your life who uses different substances, there are also support groups for people who are family members. And so those groups can also help equip you with some of the tools needed, maybe practicing how you talk about the substance use disorder with the person you love, and then what other resources there are available for them.
And kind of on a follow-on to that, how do you start this conversation? How do you start this conversation with a loved one? How do you start this conversation with a healthcare provider?
So I think it's, very different between a loved one and a health provider, right? So a loved one, you want to support them. You want to make sure that you acknowledge that you care about them and that you ask them what they think about it. Ask them, do they feel that they have a problem with substances? Do they feel a negative impact? In treatment, a lot of times we'll ask patients, well, what do you think the negative impact is? How would your life look different if you weren't using substances all the time? What would you gain? So really helping them determine what their internal motivation is can be really helpful, because you don't want to project what you want on your loved one, right? It has to be what they're ready to do. In terms of a healthcare professional, it's really important to be honest about all of the substances that you may be using, some which you may just misuse or use versus have a problem with, right? Yeah. That may negatively impact your life. And then how do you be safe with the ones if you're going to continue to use, but if you're ready, for treatment and recovery, how do you start medication, talk to them about your different health problems, other medication you may be on, and that's a really important way to sort of start that discussion. But any physician or clinical professional should treat this like any other health condition, and so that's how I would approach it. Just like you would talk to your healthcare provider about diabetes, this is something on equal footing that you should have a discussion about.
Yep. Yeah. When you're speaking with your loved one, if you notice a change in behavior, you could have a conversation with them about things that you've noticed. Are they missing family events? And ask if they would like to get back to a time where they are able to fully participate in family activities. How can they reach that goal together? So they can think about how treatment could be one avenue. Treatment and entering recovery could help reestablish that. When you're talking with your provider as well, it's important for the clinician to ask about it, but also the reason why is doubly important to be honest about your substance use is that you may be on medications that may interact with some of the substances that you're taking, and so the provider is able to provide additional education and mitigating education around that so you don't harm yourself.
All right, we're just about at time. I'm going to take one more COVID question here. Lisa Venaria on Facebook. Does the new bivalent COVID booster protect against infection with BA4 and BA5? Or will it just prevent severe symptoms like the last one? I'm getting asked a lot, why should people take this shot? Really good question. So let me bring you back in time. When the initial vaccines were made, they were designed to protect against the original strains of COVID. And the protection, if you remember, even against infection was like 90%, right? In those initial trials. I mean, amazingly protective. There is no such thing as a 100% protective vaccine. Like that is never where we are, but they were as effective as any vaccine I've seen in terms of sort of preventing illness. Where we started to really see issues with these breakthrough infections, where people often are getting COVID, like me, getting COVID even though they have had all their vaccines, was because the virus itself was mutating. And so especially, the virus wants to, evolutionarily, it wants to survive. And so it learns to alter itself to continue to be successful, to be more contagious. And the further it changes genetically from the original vaccine, from the original virus, the less full protection that you have against infection. The fantastic news is that even with the changes in the variants, the vaccine continues to have really strong protection against severe outcomes. So I want to just underscore, why do I get this now? What is different about it? The number one reason is that it's super clear that being up to date with your vaccines helps protect against severe illness. And we show this data, it's on our dashboard. Even just since Omicron, people who are vaccinated 6 times less likely to die, right? 3 times less likely to be hospitalized. But also, people who are vaccinated versus those who are not, even now, people who are not vaccinated are 50% more likely to be infected. There is protection against infection. And one of the reasons I'm really excited about this updated COVID vaccine is because, different than for the last year or so, we're back to having a match. So this updated vaccine, kind of like at the beginning, those first vaccines were highly protective. We weren't seeing a lot of breakthroughs, 1%, 2%. Now again, while it is a good match, I would expect there to be significantly more protection against infection as well. And the bivalent, remember, that means two, bi. It is both boosting your protection against the severe illness, and we really do expect helping to protect against infection for BA.4/5. There is a theory, we don't know this for a fact, but based on animal studies and some other things, we also expect that sort of having protection against BA.4/5 is covering some of these spike changes better. So even as we continue to see new variants potentially emerge, getting that updated booster, we do believe, will give you better protection. It's the same way every year we make a new flu shot, right? Why do we say you have to get a flu vaccine every year? It's because every single year we look at what strains or variants of flu were circulating in the Southern Hemisphere. This version of flu A, this flu B, and you make a vaccine that is your best guess against the strains of flu that will be circulating during our winter. There are lots and lots of strains and variants of flu, so the flu vaccine is never 100% effective. In a bad year, it might only be 40% protective if there are more strains that the vaccine doesn't protect against. We are back right now to a 99% match between what we are seeing spread and the protection that vaccine can give. And my worry is we're going to miss the window. People aren't going to choose to get that updated booster, and we will miss the opportunity on the individual level, but more importantly on the societal level, to be in the best possible shape heading into winter. I don't know whether we're going to see a new variant emerge in the way Omicron did last year. I certainly hope not, but the more people can be matched to what is circulating now, the protection will be better. So I hope that helps. No vaccine is 100% protective, but let me tell you, the boosters all along have been important. This one, by far the most important yet, because it's the first one updated to be a match. And just to sort of finish this out here, people continue to sort of chime in on substance use. Amy Rosen, on Facebook, I do appreciate, she says these Twitter comments make me sad. People who are dead cannot go to rehab. People with drug addiction are people, and they deserve protection and help. As you said, addiction is a treatable disease, but not if the person dies first. Good summary, Amy. That is also really some of what we feel. So I think I'll actually just end on that comment. I want to give you folks a chance to sort of finish up. If there's anything you really want to underscore, anything you want to remind people of in Recovery Awareness Month here.
I think the biggest thing is just if you're ready for help, please reach out. We're here for you. We have a lot of different treatment options, evidence-based treatment options. Please call the Illinois helpline. If you have a loved one and you need support, also please reach out. We're here to sort of help you in your own recovery.
And know again that treatment is available, but if you're not ready for treatment, there are steps that you could take to mitigate some of the risks. So things like carrying Narcan and using fentanyl test strips and not using alone, those can also go a long way with preventing an unnecessary death.
And we do certainly work on prevention and treatment, the whole spectrum here, but a lot of people don't know that there is medication to treat opioid use disorder. This is what I find. And I think that analogy back to the diabetes is a good one. Like if somebody has diabetes, yes, of course we work on diet and exercise, but we also treat that with medication because we know that combination, along with thinking about other things that you can do in your life to, decrease your risk, we don't judge around those needs. We think about, we want you to keep your diabetes under control. We want to keep your substance use disorder under control. That's really how we think about it. And it's important, you know, even people who are unhappy about this conversation, it's a critical conversation for us to be having. And I appreciate folks' thoughts, no matter what they are. And we're really proud of the work at the state and at the city that we're doing together. This problem is big and it is not going away. In the same way COVID is not over, substance use disorder, opioid use disorder, definitely not over. So thanks again so much for your attention. Dr. Gastala and Dr. Jasmine from the state and from the city, some of our really experts in the region around substance use disorder. So thank you so much to both of you for joining. We will be back next Tuesday, and we will potentially have a little bit of a focus on some of our environmental health work. That's another area that we've been getting a lot of questions in. It's not quite confirmed, but if not next Tuesday, in the next few weeks, I'll bring on a few guests and we'll talk about some of the work that CDPH does in the environmental health space, because that's another area, I think, like substance use, that doesn't always get as much conversation. And I think there's a lot to learn about, to think about, to work on. So with that, appreciate your attention. If we didn't get to your question, we'll save it and come back next week. As always, give us a call if you have questions. Thanks so much and have a good week.